Welcome to Raaonline. Today's topic is fever in pregnancy. So we have a case. She is gravida 3, para 2+0 with previous 2 LSCS at 35 weeks gestation, and she comes with fever and itchy vesicular rash for 4 days. So what is your clinical diagnosis and what is the infectious period? Is there a role for isolation? So what is the role of varicella immunoglobulin? What are the maternal risks of varicella in pregnancy? What is the role of acyclovir in treating varicella in pregnancy? What are the fetal risks in first trimester and up to 28 weeks in a patient who's affected with varicella virus in pregnancy? What is the role of amniocentesis in varicella zoster infection? And is the newborn a risk for varicella if mother is suffering from varicella? And how can we do the prevention of varicella virus infection in pregnancy? So, fever, macropopular vesicular pleuritic rash during pregnancy is suggestive of varicella zoster infection during pregnancy. The diagnosis is made by clinical findings of maculopapular rash with fever and varicella immunoglobulin within 10 days of index case in seronegative pregnant women acts as post-exposure prophylaxis. So, if somebody got exposed to the varicella virus within 10 days of exposure, if we give them immunoglobulin, then that is effective in preventing infection. Oral cyclovir should be started within 24 hours of the appearance of rash in pregnancy, and oral cyclovir is given in the dose of 200 milligrams 5 times a day for 7 days. And if the mother gets varicella, the fetal varicella syndrome, before 28 weeks of pregnancy, the incidence is 1%. Now, when we do amniocentesis to detect the fetal varicella infection, it has got a good negative predictive value. The maternal risk of varicella infection during pregnancy is pneumonia, encephalitis, and varicella hepatitis. So, if the mother is suffering from varicella infection at term, we should postpone delivery 1 week after rash, because during the period of rash, it is not advisable to conduct delivery. So, induction of labor or LSCS should be planned ideally 1 week after the rash has gone. Now, during the period of viremia with varicella virus, delivery is hazardous either by cesarean or normal. And as soon as the baby is born in maternal infection, we should administer varicella immunoglobulin. And if the patient is delivering within 7 days of rash or mother develops rash within 7 days of delivery and she has been getting acyclovir or she has not been getting acyclovir, the newborn should receive varicella immunoglobulin. If the patient got varicella infection, breastfeeding is not contraindicated. She can go ahead with breastfeeding with proper hygienic measures. To prevent this varicella infection, we should give a live attenuated vaccine, which is a live vaccine, so it cannot be given during pregnancy. It should be given at least 3 months before the pregnancy is planned. So, live attenuated vaccine should be given in 2 doses can be given, and 4 to 8 weeks apart 2 doses can be given, and pregnancy should be planned after 12 weeks of giving this live attenuated varicella vaccine. And after giving the second dose of this live attenuated vaccine, patient should be advised contraception for at least 4 to 6 weeks. Coming to the next case, that is primigravida at 16 weeks of pregnancy, and she develops fever, headache, retroorbital pain and myalgia for 3 days duration. So, what is the probable diagnosis and how will you confirm your diagnosis? So, very typical symptoms are being given here of retroorbital pain and myalgia. So, myalgia points in favor of viral infection and retroorbital pain points in favor of dengue infection. So, what are the 3 phases of dengue? It is the febrile phase, the critical phase and the recovery phase. What is the criteria to identify dengue hemorrhagic fever? We have to document the clinically, we can do the tourniquet test when you inflate a blood pressure cuffs and see the appearance of petechiae, or we can do a platelet count, a falling platelet count such as dengue hemorrhagic fever. What are the maternal complications of dengue hemorrhagic fever? The maternal complications include dengue hemorrhagic fever include hypotension and crisis, bleeding in the joints, and even maternal death can happen. Neonatal dengue does it have a parent to child transmission? So these are the questions which are asked in dengue fever in pregnancy.